Hello, everybody. Thanks for joining us today. My name is Chad Rathliff. I'm the Executive Director of Strategic Partnerships at Altasciences. I'm really happy to be hosting this webinar today with Dr. Morelli to discuss the golden era of GLP-1 drugs. The session is going to provide a comprehensive overview of GLP-1 agonists and their current and future impact on healthcare. GLP-1 agonists are a class of medication that mainly helps manage blood sugar levels in people with type 2 diabetes and also has weight loss effects. Other than lowering blood sugar and reducing weight, GLP-1 agonists may also lower blood pressure, improve lipid disorders, improve fatty liver disease, reduce the risk of heart and kidney disease, and delay the progression of diabetes-related nephropathy. As the market for GLP-1 drugs experiences tremendous growth, understanding their wide applications, potential risks, and effects on the economy and society is essential for anyone in the pharmaceutical and healthcare industries. So why do we focus on GLP-1 drugs? There's a number of powerful macro factors in the industry. Obesity is growing at alarming rates globally. GLP-1 is linked to a wide range of other diseases. There's increased awareness and demand for GLP-1 drugs by the general populations, and there's a number of advancements in technology. All of these trends drive investment in new treatments, GLP-1 therapeutics, and innovative breakthroughs. At Altasciences, we're focused on early development. We have preclinical, bioanalytical, phase 1 clinical, and CDMO facilities in North America to support your drug development requirements. We take an integrated approach in preclinical through phase 1 to simplify the delivery of your development programs. All of our facilities are experienced in GLP programs, having worked on multiple drug candidates over the last few years. And last but not least, we're Altasciences, and we're really happy to partner with our GLP-1 clients in the development of these drugs. And I'm really happy to take a moment now to introduce Dr. Gaetano Morelli, our Chief Medical Officer at Altasciences. Dr. Morelli has over 25 years of experience in clinical research. He joined Altasciences in 2017 as a principal investigator and became our Chief Medical Officer in 2020. Prior to joining Altasciences, he has over 10 years of other experience managing phase 1 clinical sites globally. Dr. Morelli is a clinical academic gastroenterologist at the McGill University. He's an associate professor of medicine at McGill, and he's published over 125 peer-reviewed journals. So Dr. Morelli, I'd like to hand over the slides to you and look forward to your discussion.
Hi, my name is Gaetano Morelli, Chief Medical Officer at Altasciences, based out of Montreal, and have pretty much medical oversight of our 3 sites, Montreal and Kansas and LA. And I'm also principal investigator for some studies here in Montreal. Yeah, so I thought I'd call this the golden era of GLP-1 drugs, or glucagon-like protein drugs and peptide drugs, which we know are now very commonly used for diabetes and obesity. And I think it's a golden era simply because probably worth more than gold right now, or certainly in the future. So this is kind of the history of GLP receptor antagonists. I mean, we've only really started hearing about it maybe the last 10 years. It was really first discovered over a century ago in 1906. It took many decades before associations were made between this particular class of peptides and its ability to, and it's really its function, how it worked in terms of diabetes initially and how it controlled diabetes. It was only in 2005 that the first GLP-1 was licensed for the treatment of diabetes. And that was from Eli Lilly at the time, where they picked up the drug from Amylin from Boston, from a group of researchers in Boston. And then, for many of us, we know what's happened since. In 2014, the first GLP-1 for obesity was licensed, and that was licensed from Novo Nordisk. And subsequently, Novo Nordisk in 2019 licensed the first oral GLP-1 receptor antagonist. So to our colleagues at Novo, they've certainly been very actively involved in the development and the improvement of these peptides. This is pretty much what it looks like. It looks like, for those of you who still have handheld phones, it looks like the cords on your handheld phone. The green, the blue, And gray, those are just, strings of amino acids, making this a relatively large, neuropeptide, or they're called incretins right now, simply because they're gut peptides, which act specifically to control diabetes and also obesity. And what you see in yellow are fatty acid chains, which have been added to these GLP molecules to make them more bioavailable and also easier to bind to albumin in the blood and to be transported more easily to where they're supposed to go. Now, why are these things so important? Well, as we learn more and more about the effects of GLP-1s, we realize that they really have targeted many other organ systems in our body. Besides the pancreas, we talk about effects on the stomach, effects on the brain, the heart, kidneys, the immune system by diminishing inflammation, have very positive effects on skeletal muscle. Certainly from the obesity point of view, control on metabolism of fat, both white fat or fat white adipose tissue and brown adipose tissue, which we use for basically maintaining homeostasis and maintaining our body temperature. And, many of us have heard, or many of you have heard now about NAFL or MAFL or MASH, or liver disease from steatosis, positive effect there. So given that, you can see that, why is that so important? Well, when we look at some of the potential targets that these GLP-1 molecules will have, these are some of the major indications. So obesity, and these are the numbers, these are US numbers roughly, and this was, I think, from 21. 140 million Americans are affected by obesity. And you look at arthritis, 53 million, 32 million, 37 million with chronic liver disease, 38 million, probably close to 50 million now with diabetes, heart failure, Alzheimer's, and we'll talk about some of the effects of potential benefits of these molecules in the brain, 6 million, and of course, cardiovascular disease, where you're looking at 122 million. So if you look at just this in terms of the numbers, and this is just, again, just Americans who are affected at one point in time with any one of these diseases, we can see the importance and the magnitude and why these molecules have become so key in therapy. Besides the therapy, if we look at the cost or the margins of growth of these molecules, it's estimated that we're here about right now, but as there's greater use and as we start seeing some of the generics come to market, commercial coverage becomes more prevalent, and of course the up-ramp in terms of manufacturing capacity and other big players getting into this space, and eventually, with the coverage from Medicare and again, continued increase of commercial penetration, we're probably looking in the next 5 to 6 years a market cap of about $44 billion, which is humongous. And if you look at the current state of the ones that are on the market, you can see semaglutide, which is the one from Novo Nordisk, the GLP-1. They really have the lion's share of the market, and it's estimated that their growth will continue to be and continue to maintain simply because of a lot of innovation within Novo and a lot of attention to this class of molecules to continue to maintain the lion's share of the market. So what I'd like to do is basically cover the major targets of these GLP-1 molecules and their effect on health. So we can start off with obesity, which is a prevalent, a major issue. And if you look at, this is again a map of the United States from, really within, I think, everyone's on this call's lifetime, from 1987 to 2021, and the numbers in 2024 have just gotten even worse. You can see that today, roughly about 40% of the U.S. is considered obese. Huge numbers when you take that into consideration, and hence the interest in these molecules and their impact on health. But why is obesity considered a disease? And, well, the answer is pretty simple. Obesity has such off-target, besides just being obese, a lot of off-target and affect other organs particularly. So if we can start off by, we do know that patients who tend to be obese tend to have chronic inflammatory changes. They tend to have Their blood vessels are more inflamed. Their adipose tissue tends to be inflamed. They're at risk of more inflammatory type disease like rheumatoid arthritis and other types of autoimmune diseases as well. It certainly contributes to cardiovascular disease in terms of hypertension, and because of the obesity and the lipid disorders and the dyslipidemias, contributes to cardiovascular disease, cerebrovascular disease in terms of strokes, and again has an effect on chronic kidney disease. And interestingly enough, both directly and indirectly, also on sleep apnea. And that's why in those bubble slides that I had earlier, it included sleep apnea simply because of the obesity, and the difficulty with that has an effect on the diaphragms, and so increased abdominal pressure, which causes a lot of GI symptoms, a lot of reflux. And we know that when we look at anti-reflux medication, they have a huge market penetration as well. And of course, because of the weight, a lot of mechanical effects on joints and leading to things like osteoarthritis, but certainly because of the inflammatory effects as well, contributing to worsening rheumatoid arthritis. And of course, we understand the effect on diabetes, since this was one of the reasons why these drugs were developed in the first place, and now the effect on fatty liver as well, and certainly its effect long-term in preventing cirrhosis, which is a long-term effect of or aftermath of chronic fatty liver. If we look at the global anti-obesity drug market, we can see that, in the next 7 to 10 years, the market is probably going to cap at anywhere between $8.2 billion. Again, huge market, huge monetary value in these drugs. So let's look at diabetes, which was really the first indication why these drugs were developed. And diabetes is becoming a really global epidemic, pandemic, if you want to call it. In fact, the world is becoming sweeter and sweeter every day as we talk. That's just a pun. So if you look at the U.S. and Canada, which interests us, we're looking at anywhere between 15 to even up to 20% of the population. Now, these are diagnosed. God knows how many of patients walk around, what percentage of patients walk around with diabetes that are not diagnosed. But roughly, 15 to 18% of the population here has documented diabetes. And if you focus here on the Middle East has some of the world's highest per capita incidence of diabetes. And that relates to maybe a genetic factor, genetic predisposition, but certainly their lifestyle in terms of more sedentary type of lifestyle and diet, which contributes. And Egypt and Kuwait tend to lead the Arab countries in terms of prevalence of diabetes. In fact, you're looking at 25, and in some communities, up to 50% of those communities are documented diabetics. China actually has the world's highest numbers of diabetics. I mean, they're again about 15 or 18% of their population is diabetic, but by the sheer number of population numbers, they have the lion's share of per capita. So you can just imagine the impact that these molecules will have certainly on the Chinese market once they become more and more available to that market. So these are sort of the global estimated costs of diabetes. So this is a snapshot in 2015, and they're projected for the next 15 years, solely based on the fact that unless we get control of our lifestyles, our dietary habits, our sedentary lifestyle, these are the sort of projected growths. And you can see no matter where in the world, and certainly in some of the more developing countries here, the numbers are going to become more and more astronomical and greater. So how do the GLPs work in diabetes? Well, they work severalfold. We know GLPs are, again, isolated from the gut, and their purpose in the gut and the gut lining is to really respond to meal response to being able to control insulin and being able to control sugar, so glycemias. And that's how they basically are the gatekeepers of diabetes, or maintaining homeostasis from that regards. So they increase insulin secretion, so they boost insulin release post-meal, and therefore decrease your sugar that goes into fat tissue and muscle tissue. So they lower glucose levels and they enhance pancreatic response to sugar. But they also work at the level of the brain. There are receptors of GLP-1 in the brain, which reduce hunger signals, so patients become less hungry or have early satiety, and so they have less food intake, and cravings are curbed, and that in turn adds to weight management. And we'll see as we start talk about some of the effects here in the next slides, the slides to come. Well, what about cardiovascular? From a cardiovascular point of view, this is one of our other key metabolic disorders that are very important. Well, if you look at and this is kind of scary when you look at this, the heart disease rates from 2018 to 2020 of adults age 35 by county in the US, and you're looking at sort of death rates per 100,000. You look at these states here, you're looking about anywhere between 350 to almost 500 per 100,000 deaths related to heart disease in the United States. Again, huge numbers, huge mortality rates, huge cost to the healthcare system of the US. And these numbers are pretty much replicated across North America and certainly parts of industrialized Europe and as well some of the Asian countries. And so if you look at the cost of heart disease in the US alone, it's it's anywhere between roughly $300 billion. 137 billion because of lost productivity for one reason or another, 11 billion because of heart attacks and the costs related to that. So it's estimated that within the next 10 years, the cost of just to take care of cardiovascular disease may overcome $1.1 trillion. Huge economic impact. And if you break it down, a lot of that will be direct cost of management of the disease, and others will be indirect costs, again, from loss of productivity, insurance payouts to patients who can't work, et cetera, et cetera. So how do the GLP-1s work on heart disease? Well, this is the heart, and around the heart, there is, in a healthy heart, there's always a little bit of fat tissue around there. And of course, with obesity and diabetes, which are the two leading causes of heart disease as well, you get an increased amount of this fat around the pericardium or the heart. And we know fat's a bad thing. We talked about fat causing inflammation. So you have fat, you get a lot of inflammation around the heart. That leads to irritation of the perfusion vessels of the heart and causes, as we know, atherosclerotic heart disease, etc., and then MI, heart failure, and all the costs associated with that. Well, there are GLP-1 receptors we talked about at the level of the fatty tissue here. So they're thought to decrease the inflammation, improve, again, glucose uptake there. And because of just reducing the amount of fat around the heart, really minimize inflammation of the vessels, so decrease ischemic injury that we call, and overall improve heart function in terms of better cardiac function and better heart rate. Besides the effect on the heart, on the pericardium around the heart, there are also direct effects on the blood vessels of the heart. So the lining of the heart, the thin sort of onion skin lining, we call that the endothelium, and there are receptors there. So they're thought to, what typically happens in heart disease, there are a couple of things that happen. You get dysfunction of the endothelium because of inflammation. So you get inflammation, this endothelium starts breaking down like a dried onion, and you get little broken cuts. So this causes platelets that circulate through the blood to go and try to plug these, and we call these platelet plugs. Once these plugs form, then you get fat deposition on top of these plugs, and you get basically kind of outgrowing, lumps of fatty tissue with platelets, etc. And this, of course, just like a clogged drain, prevents blood from going through, and hence ischemic heart disease, angina, and eventually, if they block off completely, a heart attack, which can be fatal as well. So the GLP-1s, thankfully, what they can do is they decrease this inflammation in the endothelium, so they improve endothelial function, so there's less breakdown there. As a secondary response to this decreased inflammation, you have decreased platelet aggregation because the platelets don't have any break in the lining here to basically stick to. you get increased blood flow, less fatty deposition on these blood vessels, and greater flow. So from that perspective, it's thought that the GLP-1 molecules have a positive direct effect on not only by controlling diabetes and by controlling obesity, which contribute to a lot of this here, but also by direct effects on the vascular endothelium itself. But what about the kidneys? We mentioned the kidney as being another major sort of health issue globally. So there are thought to be several, at least two mechanisms of action on protective mechanisms of action on the kidney. There's an indirect, which is by controlling diabetes. We know diabetes again causes inflammation in terms of the blood vessels of the kidney, which leads to dysfunction of the kidney, and then eventually developing chronic kidney disease, which in turn can cause hypertension. So it becomes a whole sort of self-feeding mechanism. So these through indirect mechanisms, again, by controlling diabetes, you lower your glycemia. It has a protective effect. By reducing body weight and reducing inflammatory mediators, we keep the blood vessels pristine and not inflamed, similar to what we see in the heart, and therefore maintain the integrity of the kidney. And we know kidney is very key as an organ to maintain blood pressure. You get kidney disease, you get hypertension. So by maintaining good health of the kidneys, you lower blood pressure. And of course, because of the anti-lipid effects of their effects on obesity of the GLP-1s, you have less atherosclerotic disease at the level of the blood vessels that feed the kidney, and therefore diminished kidney disease. But there's also thought, there's recent evidence that there's actually direct effect on the kidneys itself. They're trying to look for GLP receptors directly on the kidney. There's some animal studies that have shown, have identified some GLP-1 receptors at the level of the kidney. And these have been shown to directly decrease inflammation, improve blood flow, decrease scarring, again, from micro infarcts along the vessels of the kidney, improve or decrease oxidative stress by improving something called nitrous oxide, and all in all diminish atherosclerotic disease of the kidney, which in turn leads to chronic kidney disease, and secondarily lead to heart disease through hypertension and eventually even a heart failure. And kidney disease is a huge also market in terms of taking care of these patients with kidney disease. And it's only thought that unless we really get a good control on the risk factors, mostly diabetes and obesity, the numbers will only continue to rise. And certainly within the next 7 to 8 years, we're probably looking at close to $400 billion a year just to take care of patients with some form of chronic kidney disease. So again, we're looking at huge markets for these GLP-1s. And they've certainly now, as we've been using these molecules, peptides, for at least the last 10 years, as a class, we can see that, there's overall reduced cardiovascular and renal risks, particularly in the diabetics. So we look at cardiovascular events, 14% decrease, all-cause mortality, 12%, heart failure hospitalization, 11%, and from a composite kidney outcome, 21%. So when we think of all the large numbers overall, numbers we mentioned earlier, 21% of kidney disease is again, these are huge impacts on the overall global health of our nations. What about the brain? And, we've now identified GLP-1 receptors in the brain. So it's become a very interesting or very avid area of research as well in terms of how these molecules can affect brain health. And of course, mental health these days is a big issue. If you look at the prevalence of mental health, and again in the US, it's thought that 1 in every 5 adults will experience mental health in any given year. So we're talking about at least 20% of the population at any one time will have some mental health issues or will consult for mental health issues. When you translate that to dollars and cents, the annual cost of untreated mental illness in the US for emergency room care is about $38 billion. For incarceration, because of, we we're looking at every day, sort of some of the crises we're seeing, people being incarcerated for mass murders, shootings, et cetera, across the world. And so that is estimated to be about 37 billion just from that. From medical comorbidities, suicide attempts, everything else related to that, anywhere between 132 to 350 billion dollars. And we don't forget the loss of productivity from mental health disease, which has a huge impact. And we certainly have seen this in this COVID and post-COVID times that we've lived in the last 5 years, of how that's really impacted mental health, and in turn, the lost productivity that a lot of the industrialized countries are experiencing because of the COVID pandemic that we've had. So how are GLP-1 agonists thought to be beneficial at the level of the brain? Well, when you look at the depression models, it's thought that, so these are some of the contributing factors to depression. We talk about decreased neuroplasticity and neurogenesis. So the brain becomes less pliable, less able to regenerate, and less able to have, transmission. And, so there's an imbalance in neurotransmission because of this decreased, this plasticity. And because of that, it affects brain energy and metabolism. It's probably thought to, there's certainly some sort of neuroinflammatory process. And again, these are all from postulations and hypotheses and some studies in animal models, and trying to translate this to the human. There's a dysregulation in the hypothalamus pituitary axis here, which causes miscommunication in neurotransmitters. And again, and when you go into what's called the limbic part of the brain, which is part of our emotional part of the brain. And more and more, we're talking about a gut microbiota dysbiosis. And there's a lot of research which goes about crosstalk between the gut and the brain, and how things here affect the gut here. And we'll talk probably a little bit more about this in my next talk in the next few months on the gut microbiota. And so it'll be interesting to present that to you. So how do GLP-1 receptor agonists are thought to be beneficial to brain health? Well, they seem to improve neuroprotection and cognitive function by, again, diminishing a lot of these inflammatory processes that have also been absorbed at the level of the brain. Remember, the brain also has a lot of vessels, and there's a lot of vessel inflammation there as well. Again, so the decreased neuroinflammatory process, improve hypothalamic pituitary axis responses, particularly to stress, and they seem to regulate energy metabolism in the brain, and they seem to stabilize gut-brain axis and gut microbiota. Now, a lot of this is very tentative, research going into that, but certainly a very active area of research in terms of how these neuropeptides affect mental health. And there are some studies that presented which have looked at how GLP-1, particularly in depression, how some of these molecules have beneficial in addition to some of the antidepressants that are used. So, when you look at this side here, it favors the GLP-1 molecules compared to those patients who are not on them. So overall, their studies suggest that there is a direct beneficial effect in patients with depression who go on GLP-1 RAs. Now, some of it is direct, some of it might be indirect. Again, a lot of these molecules are used for diabetes and weight control. So is the management of diabetes, and certainly the management of obesity, contributing to some of this improvement. Again, self-images improve, overall patients' perception, their own perception of their overall health is better, and therefore may be contributing to the overall, now driving this to the left. But again, there is research showing that there are likely very direct effects to the health of the brain tissue from GLP-1 receptor agonists. So, is this really a golden era? I mean, the molecules, this the goose that laid the golden egg? Well, like anything else, there's good, there's the bad, and there's the ugly. So we've talked about the good. What's the bad and what's the ugly about these GLP-1 molecules? Well, we've seen clinically, and certainly what we at Altasciences have seen from the now, I guess, in the last few years, being involved with Novo's development of these molecules, some of the ugly part. Some of the common side effects, and actually the most common side effects of GLP-1 receptor agonists are nausea, vomiting, constipation, diarrhea, and abdominal pain. Nausea, vomiting, and diarrhea tends to be the more prevalent side effects of these molecules. And we'll talk a little bit of why that drives that way. You look at the overall, some of the bad part of these molecules, and this is the drop-off rate of patients who start these GLP-1s and then have to drop for various reasons at 1 year and at 2 years. And now these are a little kind of artificially elevated simply because most of these will look at prescription renewals. And so several things happen. If these were based on if someone doesn't renew their prescription for 3 months, they're considered a failure. Now, in the current era that we live in, a lot of patients don't have coverage for these molecules, and therefore may sort of go on to what we call drug holidays. They'll take it for a few months, stop for a few months, then go back on it. And the other thing that may be also is patients who use it for weight control, and once they achieve a certain weight target, they may go off of it for a period of time once they've achieved that target. So that artificially inflates this. But when you look at everything else and you look at it more critically, it's thought that within 1 year, about 30 to 35% of patients who go on GLP-1 receptor antagonists will stop the agonists because of side effects, either the nausea, the vomiting, or the diarrhea. And interestingly enough, most of those, well, I say most, but a greater percentage of those are in obesity patients, less so where the indication tends to be diabetes. So for whatever reason, diabetics tend to tolerate the GLP-1 RAs more favorably than patients who are using it for weight control or obesity. And I don't know what the reason for that is. So what is the effect of these GLP-1s? We've talked about their effect on health. We've seen some of the 5 major health issues globally. But how are they transforming our economy right now? Well, besides the ones that are currently on the market, the semaglutides, so the Ozempics, the Wegovy, and some of the other ones that are currently on the market, there's a lot of development ongoing to make these molecules better in the sense of better bioavailability, better in the sense of diminishing the adverse effects of nausea, vomiting, diarrhea. One of the other effects that's currently seen with the use of these drugs, particularly in obesity, the weight loss is non-discriminate. So besides the loss of fat, of peripheral fat or abdominal fat, there also tends to be some loss in muscle fat. And so in some cases, in quite a number of proportion of patients, there is loss of muscle mass. And that also leads to discontinuation of the drugs because patients are starting to lose muscle mass or cannot gain muscle mass, and therefore will stop the drug because of that. So some of the drive to improve these molecules is to make them better in the sense of better control of diabetes, in terms of so they don't get hypoglycemic, which is a risk factor. Control that, so have a better homeostasis there. Improve the adverse effect profile, improve ability to control weight gain, and again, some of the agonists here to block muscle loss. So we're now talking about dual agonists and even triple agonists. So there's a lot of research going on and development going on in putting these drugs to clinical trials as we look forward. So you can see the market continues to expand as researchers get more and more into this space. So the question becomes always the concern, and I have this here because someone asked me, are we going to run out of these patients? Once these more and more people use these molecules, what's the future look like? Well, I just put this here in terms of how we classify weight from normal weight in terms of your BMI, overweight from 25 to 29, obesity falls here, severely obese, and then of course 40 and over of a BMI is considered morbidly obese. When we look at the distribution of those categories, you can see to the right here that about 30% of the population really falls to the right of this. So the problem is, I don't think we'll ever run out of diabetes. And this is really the part of obesity that drives a lot of the diseases and disease states that we're seeing with respect to diabetes, with respect to heart disease, brain disease, and all the morbid cofactors that go along with that. And if you look at the estimated projected growth of diabetes, of obesity, not only in the world, but also in the US. And this is, look, if we're sitting here right now, in the next 10 years, it's thought that, close to 60% of Americans, a population of the States, will probably be classified as obese, and about a quarter of the world will be classified as being obese within that right-hand part of that graph that I showed you earlier. So again, you can see how when I talk about the golden era of these molecules, it becomes very, very significant. So, I mean, besides all the effects, or certainly on direct medical costs and direct medical benefits, I want to present here how it'll impact the global economy. So you look at the GLP-1s in obesity. Just by controlling obesity by 10%, it can help grow the GDP by about 2% due to reduced presenteeism and absenteeism from work, etc. So, I mean, 2% of a GDP of a major country like the US or part of Europe is really a tremendous number. It's thought that in the US particularly, it costs an extra $3,000 annually for healthcare expenditure for the management of a patient who's classified obese, so 25 BMI and over. And in terms of the labor market, and this kind of struck me I was really surprised to see this, because it's something that I certainly had no perception of. In the labor market, women who are obese experience a 20% labor cut compared to only 7% cut for men. So talk about a prejudice in the labor market. And women with normal weight earn 10% more income than their counterparts who are considered obese. So those are all interesting facts. As I was preparing for this talk, that I sort of dug into the literature. So again, huge impacts on the economy, labor market, and certainly, personal impact as well. We're all about the food industry. There's a lot of talk on the food industry. So eating habits are certainly modified by GLP-1 treatments, and I'll show you a few slides in the next couple of slides, and consumer spending as well. So what's the impact of that overall to that economy? Well, patients who've been following, who have been gone on either Ozempic or Wegovy or one of the other medications for obesity and weight change or even diabetes. So about 31% are eating smaller portions. 27% are eating healthier. 23% are eating less out, so are eating more home. 16% fewer snacks, 13% ordering less takeout, and there's none of the above. So you can see that this will have an impact. If you're eating smaller portions, your grocery bills go down. If you're eating healthier, the junk food industry, will suffer. And if you're not going out as often, well, that restaurant business will have an impact. So you can see how this has a whole impact in the economy overall. And this is sort of a projected, which is very interesting. The projected financial impact of a GLP-1 on a grocer who has a grocer chain of a $5 billion grocer chain. So it's thought that consumer spending could cut for about 6 to 9% when they use that. And from Morgan Stanley, their projection is that in the next 10 years, 7, if not 10% of the population will be on a GLP-1 on a regular basis. And what kind of impact will that have on a grocer? Well, if they just reduce their spending impact by 6%, you're talking about a $21 million cut on their bottom line. If they reduce their spending by 9%, it's a $32 million cut. And so on. So if they cut by 6%, but also decrease their wallet share declines. That means they don't no longer go to their favorite the Fruit Loops or something. It'll cut 186 million. And then if they switch stores altogether by going to healthier health food stores, that can have an impact of $350 million. So, and that's the bottom line. So really, besides the extremely positive effect on health that these GLP-1s have and will have, there's also an economic downside. So there's a lot of readjustment that has to occur. And I can tell you right now, just again, looking at the literature, a lot of the major food suppliers are already pivoting to this, understanding how the market is changing and offering healthier choices as we see, so that they can capitalize on this wallet share and not lose on that wallet share of the market. So so it bestows a lot of changes just for this one class of molecules. So basically my final thoughts. So I think, are we really living a golden era? I think in terms of, as a healthcare practitioner, to me, that it's going to have a huge impact. We are even now talking, about the effects of GLP-1s on, I'm a gastroenterologist, and diseases like Crohn's disease and ulcerative colitis, and there are some studies ongoing now, certainly in the preclinical, looking at those as models of potential benefits. So again, another area of potential benefit. So there's certainly drugs that are going to have and will continue to have a tremendous impact on global health, particularly by reducing obesity and diabetes, which are the two which contribute to the other factors, overall, heart disease, kidney disease, and I haven't even put anything there in terms of cosmetic health, because that's another huge issue from, when you look at the obesity market and the patients who spend billions of dollars on cosmetic health every year, simply because of, body images and also for medical reasons. So, we're at the dawning of a new era. And I think we can't ignore that. It's going to have not only a huge impact on health, but also a huge economic impact. And this really solely to the control of obesity, which is the major driving factor, A, of these drugs, and two, of a lot of the morbidity and mortality that we're seeing globally because of other secondary types of diseases.
Thanks, Dr. Morelli, for a great presentation. We've had a few questions come in from some of the listeners, so I thought what we could do is take a moment and go through a few of them, if you'd be so kind as to help us out here. So the first question seems to be about design of studies, and it's along the lines of, what's the typical design for a first-in-human study with a GLP-1 drug candidate? And do you ever see patients included to try and get some proof of concept data early on in phase 1?
So clinical trial research has evolved significantly in recent years with innovative trial designs. These so-termed adaptive trials are revolutionizing the way we approach clinical studies and are helping to expedite the drug development process. The primary objective of first-in-human trials still remains to determine the safe dose range, but it's not unusual within an adaptive design for an innovator GLP-1 drug to have a standard SAD, MAD design, but also to include arms such as subcutaneous, oral dosage, and also a comparator arm with a marketed drug, and an arm for early proof of concept that would include the target patient population, for example, diabetics, obesity patients, or other medical indications.
And another question here that came up is, what do you do if there is a patient on another anti-diabetic drug in a study? Are there any safety issues in putting them on GLP-1 drugs?
So that there is evidence concerning the risk of hypoglycemia with the use of GLP-1 agonists. However, the risk in healthy volunteer studies is extremely unlikely and only a few cases reported. And in a diabetic patient solely on a GLP-1, the risk still remains low. as well as the effect of the GLP-1 agonists on insulin induction, has been shown to shut down when the glycemia drops to levels below 3 millimoles or 54 milligrams. The concomitant use of insulin, and in particular sulfonylurea drug class, do in fact potentiate the risk for hypoglycemia. And so these patients will need to have closer monitoring and assessment of the CONMED for the doses being used and to reassess requirements of these con medications.
The next question here asks, are there typical biomarkers that are measured in a GLP phase 1 study?
Well, the use of biomarkers in GLP-1 trials is proving to meet some of the more common challenges in drug development, which include the ability to deliver clear efficacy and safety data, but also to help shorten the time to market. The commonly explored safety and pharmacodynamic biomarkers that are being included in GLP-1 drug development include markers such as HbA1c, C-peptide, insulin, adiponectin, leptin, and also important inflammatory biomarkers such as the CRP, IL-6, IL-1B, and TNF.
And we've got another one here. For indications other than diabetes and weight loss, are there other therapeutic areas that you're watching?
We are, in fact, the GLP-1 therapeutic field is exploding beyond treatment of obesity and diabetes. Some of the more recent studies have reported beneficial outcomes in cardiac and renal disease with significant reduction in morbidity and mortality. There is evidence to suggest that the impact is not only related to the improvement of diabetes and weight reduction, but also there may exist direct effects on inflammatory markers and possibly endothelial anti-inflammatory properties. Another area of interest in research is in substance abuse disorders. There is some recent studies that have reported up to 40% consumption reduction in opioid use as a result of GLP-1 receptor agonists on brain receptors that are involved in cravings and dependency. There's also some significant research interest in the field of fertility. In obese males, the use of GLP-1 agonists has shown to enhance sperm metabolism and motility. In women, improved ovulation rates and regulating menstrual cycles. However, the mechanisms are not yet clearly understood, and more research is needed to confirm whether medical weight loss affects fertility directly, or there actually exists a possible direct action on the reproductive system.
And I think we've got time for one more question, Dr. Morelli. Here's another one that came up. The GLP-1 drug development field is becoming increasingly competitive. Are there potential strategies that could help accelerate development?
For sure, next generation GLP-1 drug development will focus on a combination of GLP-1 agonists with other enteropancreatic hormones with complementary actions and or synergistic potential, such as the addition of glucagon, amylin, glucose-dependent insulinotropic polypeptide or GIP. So innovators will need to make strategic choices about which opportunity segment to invest their assets in. This in turn will determine their competitive strategy. For example, which specific unmet need their assets will address, and also who to differentiate and how against a field that's becoming increasingly saturated. So it's important to address these evolving needs along the patient journey as the patient transitions from induction therapy to maintenance therapy. So potent injectable, for example, and an oral therapy or combinations of the GLP with other synergistic molecules will help address the more complex needs to address therapy for multiple medical comorbidities. And this will be a key strategic move for innovators in this field. So it's been my pleasure joining you today on this remarkable journey through the era of GLP-1 drugs and the incredible impact they are having on not only medical diseases, but in global worldwide impact in other areas as well. I would be more than happy to entertain further questions, and I am available at the email below.
Okay, great. Dr. Morelli, thank you very much for your time on this Q&A. I'd like to thank all of our attendees and listeners today for the webinar with Dr. Morelli. If you do have any follow-up questions, you can feel free to send them in to our team, and we'll have Dr. Morelli follow up with you as well. Thank you very much.